Hello guys, how are you? Today I came back with a different video. As you know, we have started a series about infectious disease. So today's topic is another gram-positive microorganisms called the Clostridium tetani. So from the Clostridium species, we will also discuss about the Clostridium difficile by the next video. So we will have some brief discussion about the pathophysiology, the epidemiology, and finally about the clinical management summary of this Clostridium tetani species. So let us study together. So as an introduction, what is Clostridium tetani? As an introduction, Clostridium tetani is one of the gram-positive microorganisms that you can see in nature, and it is a rod-shaped type of microorganisms. They are anaerobic, and more than that, they are spore-forming. They are spore-forming microorganisms. How is Clostridium tetani transmitted from person to person? Transmission. The transmission of this Clostridium tetani from person to person, usually a person acquires this microorganisms or the Clostridium tetani from the soil. So the reservoir is soil. The reservoir is soil. So when you have a soil, when you have a skin breach, and when this Clostridium tetani has an access to enter into our body, basically will develop this problems. And because, as I mentioned before, and as I mentioned before in the previous videos, Clostridium tetani they are spore forming microorganisms, which means they can stay in the soils or in the non-favorable environments for long period of times. For longer period of time. For example, Bacillus anthrax can stay for about 15 years without affecting anything by keeping its spore. So it is the reservoir it is soil. So when you have the skin breach with contact with soil, the likely to develop this Clostridium tetani is high. The another point is, what is the pathophysiology? So let me summarize simply. Now there is spore in the soil. Spore in the soil. And when this spore soil has access to the microorganisms, they started to germinate at lower oxygen level because they are anaerobic. They are anaerobic. So germination will be started inside the cell. Germination cells will be started inside the microorganisms. Then this Clostridium tetani started to produce two important toxins. The first one is tetanospasmin. Tetanospasmin. The other one is tetanolysin. Tetanolysin. Basically, this tetanospasmin is the one that is responsible for the total pathophysiology and natural course of the diseases. But tetanolysin usually it causes tissue damage. This one is a tissue damage, and this one cause it is a neurotoxin. This tetanospasmin, it is a mechanism of action of this tetanospasmin is what it does. It's block the inhibitor neurons. The inhibitor neurons, what are these? The GABA inhibitors and the glycine. So when the inhibitor neurons are blocked, like GABA and glycine inhibitors are blocked, when they are blocked, they cannot undo the excitation. So there is a positive neurologic excitation that started from the brain. There is a muscle, there is an excitation process, a positive forces, and there is a counter forces that is mediated by GABA and glycides in order to block, because if it is not regulated with negative neurotransmitters, there will be a continuous excitation to the muscles, and this muscle will contract upon excitations and relaxes about inhibition. But if the system is blocked, there will be a continuous excitation to the muscles from the brain system. So there will be rigidity and spasm will be happen. That is the general mechanism of action of tetanus toxoid. Another important point about this is tetanus clinical manifestation. Let's start to discuss about the clinical manifestation. Clinically, based on this clinical manifestation, tetanus has four major clinical manifestation. The first one is it is local tetanus. Local tetanus is, for example, if the patient has a wound over his arms and he has contacted the soil and the microorganism has an access, so the patient experiences this spasm or this local muscle rigidity. the patient will experience this local muscle rigidity. There is no systemic manifestation. It is confined to the injured area. The second one is there will be a cephalic tetanus. This cephalic tetanus, it is very dangerous one. The second dangerous one after the neonatal one. It is most commonly involved the cranial nerves. Cranial nerves will be involved by this cephalic tetanus, and the most common cranial nerve that is involved is the cranial nerve or the facial nerves. So at early times this cephalic tetanus can cause pharyngeal muscle spasm or laryngeal muscle itself. So pharyngeal spasm or laryngeal spasm can be happen from this patient, and the mortality of this patient will be high when the patient has this dysphagia and aspirations. The mortality will be high. The third one is it is a generalized tetanus. And it is the most common form of tetanus. This tetanus has 3 phases of clinical presentation. So the first 3.1 clinical presentation or the early sign of this tetanus is there is lockjaw, or sometimes it is called trismus. Basically there will be a hypercontraction of masseter muscles, so the patient will have this lockjaw structure. The patient has difficulty to open his mouth because the masseter muscle is strictly contracted. But associated with the patient has this back pains, and dysphagia may be difficult can be experienced. The second, after the lockjaw, the next natural cause will be it is a fascial involvement will be happen. Fascial involvement. There is a term called rhizus sardonicus. It means evil smile. Yeah, evil smile. The patient facial muscle will contract because of most common cranial nerves. It is involving is cranial nerve 7. So the patient facial muscle all are contracted. So the patient has this kind of weird smile like feature the patient will have. So that is called rhizus sardonicus. And the last one of this clinical manifestation will be it is called progression. So the patient will have this generalized tetanic symptoms, and finally in severe course is the patient could have this opistotons, or it is arc of the back will happen in this patient manner. So the other and the last type of this tetanus is it is called neonatal tetanus. Neonatal tetanus is another big and lethal form of currently because of the development of vaccines during pregnancy. The patient usually the babies are safe from developing this neonatal tetanus, but usually this neonatal tetanus is acquired when the patient delivered these babies at local health centers or at home deliveries. There will be a poor umbilical cord caring, so the baby can have this severe form of tetanus. So it is usually related with umbilical cord care related. So this generalized type of tetanus have 3 type of clinical presentation based on its severity. So generalized tetanus, this generalized tetanus has 3 form of clinical presentation. The first one is it could be mild. How do you differentiate mild from moderate and severe ones? The mild one is incubation period it is more than 14 days, no autonomic nervous system dysfunctions, no ANC dysfunction, and mild, the patient has this mild spasm. And the second one is this moderate one. In the case of moderate, the incubation period is between 7 days up to 14 days. The patient has this marked rigidity, and the patient has mild dysphagia, but again no autonomic dysphagia. Mild marked rigidity and mild dysphagia, but no autonomic nervous systems dysregulations. There will be no such kind of symptoms. And the third one is there is a severe tetanus. In the case of severe tetanus, usually it develops between less than 7 days, and sometimes within 3 days this tetanus can be started. And these patients usually have severe muscle rigidity and asphyxia. And the other one is there will be ANS disturbance, autonomic nervous system disturbance. there will be autonomic nervous system will be different. So what are the autonomic nerves that are disturbed because of this tetanus toxoid, or what are the ANC dysregulation? The first one is the hypertension will be elevated. The hypertension will be elevated. The patient have this excessive diaphoresis. The other one is the patient become tachycardic, and the last one is there will be the likely chance of developing arrhythmia. These are at severe cases the patient could have this kind of symptoms. In the case of severe back arcing, the patient can have these vertebral fractures and rhabdomyolysis. In the case of after rhabdomyolysis, the development of nephropathy or nephrotoxins, aka it is because of the myoglobin will be high. So how do you diagnose? So these are the clinical things that help us to diagnose. So how do you diagnose the patient with tetanus toxoid? So usually clinically about 20 up to 30% only come up with a history of trauma. So the other patients are not, they may not remember or they may not experience any type of or sort of any certain type of skin trauma. And the other one is spatula test. What is spatula test? Spatula test is you hold a spatula and you just scrub the pharynx of the patient. So if the patient respond and if the patient contract or if the patient stay open, there is different. If the patient is contracted, the spatula test is positive, and it is open, it is negative. So if it is contracted, because we are inducing the masseter muscle to close up. So the likely chance of tetanus is high, but it is not 100%. This is how you clinically diagnose. Another mode of diagnosis are you may do blood culture. It's also most common. So blood culture will be another important topic. So how do you manage the tetanus patient? How do you manage tetanus? The first principle of management is there must be immediate measure must be taken. Immediate measure. What are these immediate patients? Airway. What are the airways that are essentials? For example, if the patient can't support airway breathing because of the spasticity of this laryngeal or pharyngeal muscle, as I mentioned before, in the case of cephalic tetanus, the patient must be supported with airway. So we need to either intubate the patient or tracheostomy must be done. Tracheostomy must be done. So when you compare about the clinical relevance of intubation versus tracheostomy, for the tetanus patients, tracheostomy is the most preferred one, because in the case of laryngeal intubation, the patient may have experienced or just triggering of this laryngospasm. Laryngospasm might be happen. Another important thing is oxygen must be supplemented for these patients before they pass away. Then once oxygen is supplemented, the immediate thing is we need to provide a human tetanus immunoglobulin about 500 milligram IM-stat. This must be immediately provided as soon as possible. And the last one is there must be a wound care. This is the immediate measures you need to take on the tetanus suspected patient. So what are the second one? The second one is you provide antibiotic for this patient. So the elements of microorganisms, just to cover the antibiotics or the preferred antibiotic is metronidazole. Metronidazole 5 milligrams IV 3 times a day. Okay, sorry for the slight technical problem. So the first line of management for Clostridium difficile from the Clostridium tetanus, the first line of management of antibiotic is metrondazole. And when you compare that with metronidazole and the penicillin, metronidazole it has a better, because penicillin has some researches have indicated that this penicillin have some effects over inhibition of this GABA and the glycine. So if you provide this penicillin, the likelihood of exacerbating this GABA and glycine inhibition will be high. So we don't need to provide penicillins. But if the patient is allergic for the metronodazoles, the preferred type of penicillin we need to provide it is penicillin G. penicillin G must be provided for the patient. The third principle of management is we need to control the spasm. So the patient have this sometimes periodic, sometimes the periodic may be regular or irregular type of spasm of the peripheral muscles. So these muscles must be controlled because it is very painful for the patient. So the first choice of the patient is it is benzodiazepam. Benzodiazepam like diazepam, midazolam. These are the first choice of magnesium control for the sulfate. The other option is magnesium sulfate, and this magnesium sulfate is better controlling the spasm. They also important to control the autonomic nervous system. We will discuss it later. We may put the patient on propofol infusions, and we may provide this neuromuscular blockers like Vicronium. Vicroniums may be provided for the patient in order to minimize the pain. So 1, 2, 3. So once we control the spasm, the next mode of management will be we need to control the autonomic dysfunction. We need to control the autonomic dysfunctions. So as I mentioned, there may be hypertension or hypotension, tachycardia, or the patient may experience arrhythmia or excessive diaphoresis or sweating. So in the case of controlling our autonomic nervous system principle, what we are doing, basically our most common medication is magnesium sulfate. It has loading and maintenance doses. In the case of loading, we are providing about 70 to 80 milligram IV milligram per kg IV over 20 to 30 minutes. The medication will be provided. This is a loading dose. Once the patient is loading with magnesium sulfate with 70 to 80 milligram per kg, the next step will be we will provide us a 2 gram. Then the next step is maintenance. The dose of maintenance is depending on two things: if the age is less than 60 years and if the age is above 60 years. If the age is less than 60 years, the patient, our dose will be 2 gram per hour. But if the age is above 60 years, our dose will be about 1 gram per hour. Then we will follow the patient clinical conditions and its responses. So every 6 hours we will escalate 0.5 gram per hour. Every 6 hours we will escalate the maintenance doses until we are targeting. So what are our target? The target of our target is we need to control the spasm, and we need to control the autonomic nervous system dysfunctions, and we need to keep the magnesium level, the serum magnesium level between 2 to 4. It is a therapeutic range. So we need to keep it at this level. So what do we follow while we are providing this magnesium sulfate? So we need to know the magnesium sulfate toxicity. So what are the most common magnesium sulfate toxicities? The first one is we have depressed respiratory rate, we have depressed pathera or dependent reflexes, and we could have serum magnesium level. The magnesium level we skyrocket, it can increase, and the calcium levels can be decreased, or hypocalcemia will be a potent complication. So what will you do if we see these symptoms? Immediately we need to stop the magnesium sulfate and we need to initiate calcium gluconate. We need to immediately initiate calcium gluconate. Okay, the fifth mode of management will be it is a supportive management. We need to provide DVT prophylaxis. We need to start feeding. We need to make it physiotherapy, and we need to prevent bed sore. Bed sores must be prevented. So finally, with adequate, the last one is once the patient is immediately treated and clinically improved, we need to provide immunology, because this HIT or human toxoid immunoglobulins does not basically help us in order to change the further or the late clinical complications. So we need to vaccinate the patients. If the age is 7 years and if the age is above 7 years, if it is below 7 years, we need to provide DPT, and if it is above 7 years, we need to provide diphtheria toxin, diphtheria tetanus. So if with adequate treatment, the survival or the prognosis rate of this Clostridium tetanus is around 10 up to 20%, and the patient usually recover within about 4 up to 6 weeks recovery. from psychological and physical disease may require for up to 6 weeks actually. So the poor indicators of tetanus are the first one is neonatal tetanus. If the incubation period is less than 7 days or it is above 3 days, and if it is autonomic nervous systems are dysfunctions, if they presented, the clinical outcome of this patient might be poor. Another important point that I would like to add in the place of neonatal tetanus is usually neonatal tetanus developed after the age of 2 days, not in the same day, after the age of 2 days, and it may last from 3 up to 21 days. It may last from 3 up to 21 days. So guys, this is all about the Clostridium tetani. Let's stay tuned for the next our Clostridium deficient videos. So bye bye.